This paper was the first chink in the armor of the story that high testosterone is bad, low testosterone is protective. Low testosterone was not protective against prostate cancer. What about high testosterone? When we pulled all the papers we could find about testosterone and prostate cancer, the number of papers that we found that showed something worrisome about high levels of testosterone or testosterone therapy in prostate cancer was exactly 0. This concept was taught to medical students around the world, and yet we could not find any evidence for it.
Can you just tell me quickly what was this session today about?
The session today was to present the differences or challenges that we face in practice regarding following guideline recommendations versus having to make decisions for individualized patients that come to you for care that may not necessarily fit the exact profile you would like for a guideline recommendation. That's what today was all about.
James, why is it so important to have reliable data for making medical decisions?
Historically, as you know, medicine or urology, if we're talking about this specialty, has depended heavily on eminence-based medicine. Very experienced surgeons making decisions they feel from their experience are the right ones for patients. Where now we do evidence-based practice where we rely on high quality evidence to determine how we care for patients. And that's the way that we should be going, and that's the future.
Sometimes what people think is right turns out to be wrong. You can give us an example about testosterone therapies. What happened there?
Urologists have had an idea about the relationship between testosterone and prostate cancer that was based on work performed in the 1940s, before we even really had good measures of prostate cancer like with PSA. And now, as we've been using more testosterone and seeing its value to men, some of the old ideas appear to not be correct anymore. So it's no longer true, or based on the evidence, that giving testosterone to men is like pouring gasoline on a fire.
So you think it would be important to provide this data also to medical colleagues around the world?
So I've been doing a fair amount of this work for years, and the more that I do, the more I see the possibilities. So testosterone helps men with sexually, with energy, with blood sugar control, with bone density. It's important for men. And we've had this theoretical concern that made it almost impossible for us to even think about treating these men. I think as we learn more and as we get more evidence, we find that the data are more reassuring, and we can start looking at the whole man instead of just a theoretical concern compared to actual benefits.
Speaking more general, how can we assure that important new medical data really enters into medical practice?
So that's where I think a guidelines office role is important, because it's independent, and we hope that the views that the guidelines office puts forward is unbiased, and hopefully will align with the best evidence that is available, obviously. And so it is important that we in surgery, it's not so easy for us as surgeons to do randomized trials. It's not so easy, but I think we must be committed to doing that, because when you do some studies well, you find that what we thought, as you were saying, what we thought before actually is not actually true.
Do you agree on this?
Medicine and scientific knowledge moves forward, sometimes in little steps and sometimes in dramatic steps. But the idea that it's fixed and we can make a decision today is really a myth. So we do the best that we can, and we have to be humble about the information we have, and we have to be open to the idea that things change and there will be new ideas, and we have to accept them as the evidence comes in.
Thank you so much for talking to me.
Thank you.